Today we're going to talk about some common questions, misconceptions, and myths about carpal tunnel syndrome. Nothing to disclose. So some common questions that may come up with patients who are experiencing carpal tunnel syndrome or wondering if they're experiencing carpal tunnel syndrome are, I have hand pain. Is it carpal tunnel syndrome? I have hand numbness. Is it carpal tunnel syndrome? What causes carpal tunnel syndrome? Is it caused by my job, by typing? Does it always worsen with time? You may have mild symptoms now, but is it going to get worse, or is it going to stay the same or get better? Will I develop it in my other hand if you have it on one side? Is surgery the only treatment? Are steroid injections an option? Can they be a permanent solution or only offer temporary relief? There's several different ways to perform the carpal tunnel surgery, the surgical release. What are some of the differences between those? And then if you do have carpal tunnel syndrome on both sides, options for treating it on both sides at the same time or in a staged manner. So common causes of pain in the hand, there can be a number. So nerve pain, a nerve issue can cause pain in the hand, arthritis, tendon issues, fractures and ligament injuries. Of the causes of hand numbness, carpal tunnel syndrome is certainly one of the very common ones, but there are other causes of hand numbness as well. There could be other nerve compressions, whether it be from the spine or at a different site or a different nerve, and then peripheral neuropathy more generally can cause sensation of numbness in the hand. So just a little bit about carpal tunnel syndrome. It is the most common compressive neuropathy of the upper extremity. There's greater than 500,000 surgical procedures performed for this every year. The overall economic impact is about $2 billion. It does more commonly affect females than males. Most commonly, it's patients who are 40 years or older. And there is the association between workplace issues or overuse. There's some mixed studies on that, and we'll talk a little bit about that later. So carpal tunnel syndrome, the nerve that's affected in carpal tunnel syndrome is the median nerve, and it's specifically affected at the wrist. And that nerve supplies sensation to the area demonstrated on this slide, so the thumb side of the hand primarily. And what patients typically experience is numbness, paresthesias, which is tingling in the fingers. They can also experience pain. Often the symptoms are worse at night and may cause a patient to awaken at night or with use of the hand. Relief, patients may describe when they wake up at night that they reposition their hand or shake it to obtain relief before being able to go back to sleep. Can also cause pain in the palm or in the wrist, which may radiate towards the fingers or up towards the forearm and elbow. Patients may describe sensation of the hand feeling swollen, feeling weak, clumsiness, especially with small objects and dropping objects due to either weakness or difficulty feeling them. One other sign and symptom of carpal tunnel syndrome that we look out for is weakness, but specifically when the muscle that moves the thumb and brings the thumb across the hand is becoming weak and decreasing in size. That can be a sign of severe carpal tunnel syndrome. So that's something that we keep a close eye out for in patients who may be presenting with this. Carpal tunnel syndrome, as I mentioned, is when the median nerve is compressed at the level of the palm and wrist, and the median nerve travels in a tight tunnel in this area that's also occupied by the tendons that move the fingers and thumb. So there's 9 tendons in the nerve in a tight space that doesn't have much room to expand. So if there's any swelling in that area, or if the space has become tighter with time for any number of reasons, it will compress the nerve and cause the symptoms consistent with carpal tunnel syndrome. There's alternate sites of compression for the median nerve higher up. One of them is as it pierces the peroneal teres muscle. We won't talk about that too much, but it's something that surgeons need to look out for as a potential alternative site that can cause very similar symptoms. Causes of carpal tunnel syndrome There are multiple. So a fracture, an acute traumatic event, can cause mechanical pressure on the nerve. Prolonged pressure in the palm, there's been some studies that have shown that can either exacerbate symptoms or lead to symptoms. Occupational associations, there has been some association with repetitive and forceful tasks or with handheld vibration instruments such as operating a jackhammer. People who do those things have been shown to have a higher rate of having carpal tunnel syndrome. There's not been a clear association with typing or use of a mouse or keyboard specifically. There are several conditions that predispose patients to having carpal tunnel syndrome. Diabetes, inflammatory arthritis such as rheumatoid arthritis. There's a condition called amyloidosis in pregnancy, and then also obesity. Patients with those conditions have a higher rate of having carpal tunnel syndrome. And then there's genetic predisposition, especially in patients who have both wrists affected. So just a quick review of some of the literature on these exposures. Patients who are exposed to vibration at work have an odds ratio of 1.6, increased risks of carpal tunnel syndrome. Workers who perform tasks both with high force and high repetition have a higher rate of developing carpal tunnel syndrome. There hasn't been a clear association in the multiple studies looking at it that at the association between computer use and carpal tunnel syndrome, as I mentioned. Regarding the comorbidities, so obesity, diabetes, and hypothyroidism have been shown in multiple studies to have a higher risk of developing carpal tunnel syndrome. In one study looking at obesity specifically, each 1 unit increase in BMI increased the risk of carpal tunnel syndrome by 7.4%. Amyloidosis is a serious systemic condition, and more recently in the literature there has been some associations shown between patients with amyloidosis and having bilateral carpal tunnel syndrome specifically. So that's being looked at more carefully and specifically lately within the last 5 years or so. And then rheumatoid arthritis and psoriatic arthritis, patients with these conditions have a higher prevalence of having carpal tunnel syndrome. So looking at genetics, they haven't identified specific genetic markers per se that predispose patients to carpal tunnel syndrome, but in patients with bilateral carpal tunnel syndrome, 45% have a family history of it versus 27% with unilateral, and patients without carpal tunnel syndrome, only a 12% rate of having a family member who had carpal tunnel syndrome. So there's clearly some genetic predisposition. Overall, the incidence of having bilateral carpal tunnel syndrome in patients who present with carpal tunnel syndrome is in the range of about 60 to 80% across multiple studies. In this one study, all comers that presented with carpal tunnel syndrome, about 59% had bilateral symptoms. When they looked at nerve conduction in EMG studies, in patients who only presented with symptoms affecting one hand, about 57% of those patients, the other side showed evidence of carpal tunnel syndrome on the nerve conduction in EMG studies. And then in 76% of patients with asymptomatic hands, they did later go on to develop carpal tunnel syndrome in that asymptomatic hand at an average of 3.2 years. So it is quite common that it affects both hands. I briefly talked about nerve conduction and EMG studies. This is one of the ways that we can establish a diagnosis of carpal tunnel syndrome outside of an assessment of the patient's signs and symptoms in the office. And it does provide objective evidence of compression of the median nerve. It's a combination of two different studies, one where electrical impulses are stimulated across the nerve, and you can measure the amplitude and velocity that the electric impulses travel down the nerve, and then the other is using a needle to record the electrical activity in the muscles that are innervated by that nerve. So it's a combination of two different tests, and it supplements our clinical assessment of the patient. Regarding the natural history of carpal tunnel syndrome, the severity and symptoms of carpal tunnel syndrome may progress, but not always. So in this study from 2008, they followed 132 patients who received no treatment for their carpal tunnel syndrome over 2 years. About half of the patients did recover and no longer had symptoms at the end of that 2-year period. 29% remained unchanged, and then 23% had worsening of their symptoms. Regarding their nerve studies, 67% were mostly unchanged, 25% did improve, and 8% did deteriorate. So there is definitely a subset of patients who do progress in terms of their symptoms, a subset who symptoms remain unchanged, and then a subset who can have recovery, especially in patients with more mild symptoms. So regarding treatment options for carpal tunnel syndromes, non-operative treatment options typically include using a splint on the wrist, specifically at night. It tends to be the most helpful. And then an alternative to that, or in addition to that, corticosteroid injections can be an option for treating carpal tunnel syndrome. So the efficacy of splinting, it has been shown to be effective in mild to moderate carpal tunnel syndrome. A number of studies have shown that consistently that patients do experience a significant improvement in their symptoms with splinting, especially nighttime splinting. And then regarding steroid injections into the carpal tunnel, they do reliably provide short-term relief. There is, however, a potential high rate of return of symptoms, especially beyond 6 months. In one study, 32% of patients did not end up requiring any subsequent treatment after a single steroid injection, and that was patients followed for over 7 years. The flip side of that is that 70% of patients did require subsequent treatment. So it does reliably provide some relief, but the percent of patients who have permanent resolution of their symptoms is on the magnitude of 20 to 30%. So something to consider. Efficacy of other kind of alternative treatments have not consistently been shown to provide significant relief for these patients or resolution of symptoms. So PRP, medications like gabapentin, physical therapy, exercises specifically targeting the nerve and motion of the nerve, so nerve glide exercises and acupuncture have had some mixed results in the literature, but none consistently showing reliable relief of symptoms. The most reliable treatment for carpal tunnel syndrome is surgical carpal tunnel release. And this is releasing the transverse carpal ligament, which is a tight ligament overlying the nerve and those 9 tendons that we discussed. And there are 2 primary ways of performing this surgery. One is open carpal tunnel release, so making a small incision directly over that ligament and releasing it sharply with a knife. One of the downsides of this approach potentially is that there can be some tenderness or what's called pillar pain directly over the site of the surgery, which can last up to 6 months to a year potentially. It is usually mild, but it is something to consider. It does have a very low revision rate of needing a subsequent surgery to readdress the carpal tunnel syndrome. And then a more somewhat newer approach to treating this is doing it endoscopically, so that's with a smaller incision and using a camera to visualize that ligament, and often cutting the ligament along the undersurface under visualization through a camera. This has shown an earlier return to work, less scar tenderness. The incisions are usually placed out of the site of the palm, so they're not directly being pressed on with most tasks such as computer use or writing or typing. So patients complain less that they experience tenderness at the site of the scar. There is possibly a higher revision rate, and there is possibly a small increased risk of having a temporary nerve injury with the endoscopic carpal tunnel release. So these are pictures of what you may expect after a carpal tunnel release surgery. So the size of the scar Comparing on the right is a drawing of approximately how big an open carpal tunnel release incision may be versus the cartoon on the bottom right showing an endoscopic release where the small scar is placed more proximally. And then typically patients with either approach will have a light dressing on their hand and able to use their hand immediately after surgery for light tasks. In patients with bilateral carpal tunnel release, often we have a conversation with patients about whether they want to address both sides at the same time or in a staged manner, and staged can be a couple of weeks apart or longer, depending on the patient's preference. Simultaneous carpal tunnel release has shown faster return to work. There can be some difficulty with activities of daily living and self-care, specifically those first 2 to 3 days after surgery. A study in 2014 that polled patients after either staged or simultaneous surgery demonstrated that patients who had the surgery simultaneously needed assistance about 45% of the time with hygiene at home, versus patients who just had one side done at a time. Only 22% of those patients needed assistance with hygiene at home. Thank you.